Hello, dear students. This is the first lecture of the second semester of 158. So if you want to follow along in your book, if you want to follow along with the PowerPoint, please go ahead and get that out and get ready to take some notes. This is chapter 19. We are going to discuss the first part of the cardiovascular system, which is going to be blood. First and foremost, we are always going to start with the function of whatever it is that we are talking about, and today that is going to be the function of blood. There are 7 primary functions to blood. The first is going to be for the transportation of gases, nutrients, and waste products. For example, I want you to think of the fact that blood is going to transport oxygen and carbon dioxide to or from the lungs. It is also going to transport ingested nutrients, ions, and water. This is going to be coming from the digestive system. And we are also going to be transporting other cell waste products to the kidneys to be filtered out. The second function is going to be the transportation of processed molecules. For example, the precursor of vitamin D from skin to the liver, then to the kidneys. This is going to end up promoting calcium uptake once we finish that whole process, but it's a very important process. The third function is going to be the transportation of regulatory molecules. For example, this is hormones, so think back to the endocrine system and how we discussed the difference between the endocrine system and the nervous system, how the nervous system is going to transport neurotransmitters through nerve cells versus how hormones are going to be transported through the cardiovascular system. The fourth function is going to be the regulation of pH and osmosis in blood specifically. So these buffers within the blood are going to help maintain a normal pH. And this is going to be pretty much for the whole body. So what the pH of the blood is typically going to be what your body's pH is going to maintain. Number 5 is the maintenance of body temperature. So this is thermoregulation. So it's going to be where your warm blood is going to be shunted into the interior of the body. It's going to push heat into various places, and also if you are in an extreme environment where your body needs to make decisions on what to keep warm, it will always choose that central axis to keep warm. And that is why in extremely cold climates, if someone is stuck in a very cold area, they may have limbs that need to be amputated due to a lack of blood flow and warmth to those areas. So fingers, toes, nose, various things like that. So your body is going to prioritize that central area for warmth. The sixth function is going to be the protection against foreign substances. This is going to be in the form of antibodies. We'll talk more about that later. And then the seventh function is going to be clot formation, and this is going to be through platelets or thrombocytes, and we'll talk about those later again. But this is going to be where we have tissue repair and restoration when and if it is needed. Moving on to the composition of blood. Blood, remember, is a connective tissue, one of those 4 main tissues that we had to know in 157. So the first was epithelial, then connective, muscle, and nervous tissue. So this is a connective tissue, which means that it is a cells within a matrix. And in this case, blood is really unique because it is a liquid matrix that contains cells and cell fragments. Plasma is going to be a part of blood. It is the liquid matrix and composes about 55% of your total blood volume. So the majority of your blood is plasma. The other part of blood is going to be called formed elements. These are the cells and cell fragments that make up your blood. This is going to be about 45% of your total blood volume. And then do make a little note that there is a difference between blood volume in females and males. Males will on average have a larger amount of blood volume. Here we have just this lovely picture here of if we were separating out the various components of blood and that breakdown, and we are going to talk about all of these things a little bit more in depth. All right, moving on to plasma. So that is that liquid matrix within our composition of blood. So plasma is going to be known as a colloid. Colloids are a liquid containing suspended substances that don't settle out of solution. And then do keep in mind that most of the suspended substances within our plasma are going to be our plasma proteins. But kind of read the slide through as well. Most of plasma is going to be water, and that should be a pretty good indicator that the majority of your blood is actually just water. But the remainder is going to be those proteins that I just mentioned, ions, nutrients, waste products, gases, regulatory substances. When you take some type of medication, it's going to be moving through in your plasma, not in the formed elements, etc., etc. So moving into these plasma proteins, the plasma proteins themselves make up about 7% of plasma, and they can be separated out by their size. So these three groups are separated out by their size and a little bit of their function as well. The first is going to be albumins. Albumins make up about 58% of plasma proteins. They are going to regulate movement of water between tissues and blood, as well as regulate the viscosity and osmotic pressure of blood. They're going to contain buffers, transport fatty acids. They are going to contain free bilirubin, and we'll talk about what that means here in a bit, as well as thyroid hormones. The next is going to be globulins. Do not confuse this word for goblins. I've seen a few students write it out incorrectly. Make sure you know it's globulins. This is going to make up about 38% of the plasma proteins. They are going to contain what is most important, I think, is going to be antibodies. Antibodies are globulins that protect against microorganisms, and we'll talk more about antibodies here in a minute, but do make sure you underline that little bit there. Globulins are also going to transport lipids, so keep in mind those are fats, carbohydrates, hormones, ions, and again, make sure you know that they are antibodies that they are going to be transporting there. The last one is going to be fibrinogen. Fibrinogen is going to make up 4% of plasma proteins, and these are going to be involved with blood clotting, which is a very, very important thing that we need to keep in mind. And then make a little note here that serum, S-E-R-U-M, I'll spell it out for you here, guys. S-E-R-U-M is going to be plasma minus clotting factors. So if we took the plasma out of our blood and then we also excluded any clotting factors, including fibrinogen, we would get something called serum. Continuing the composition of plasma, do make note that there are ions involved in osmosis, membrane potentials, and acid-base balance, and some of those ions include sodium, potassium, calcium, magnesium, chloride, iron, phosphate, hydrogen, hydroxide, and bicarbonate. Now you don't need to know all of those by heart, just know, just in general, that those are the ions involved. We are going to have nutrients in our plasma. The main ones I want you to know: glucose, amino acids, and vitamins. Our waste products are going to include urea, uric acid, creatinine, ammonia salts, and just kind of keep in mind that all of those are going to be basically the breakdown products of protein metabolism, so kind of just basic cell waste, if you will. We are going to have bilirubin, which is a waste product from the breakdown of red blood cells, and that is going to be occurring in the liver. We're going to have lactic acid, and this is an end product of anaerobic respiration. So think about back to when we were talking about muscles, how lactic acid is a waste product of anaerobic respiration. We are going to have gases in our plasma, so a little bit of oxygen, but not anywhere near how much oxygen our red blood cells can hold, but a little bit is going to be in our plasma. Carbon dioxide and inert nitrogen. And then we are going to have some regulatory substances such as hormones and enzymes. Next, we are moving on to our formed elements. Formed elements are going to include red blood cells, white blood cells, and platelets. So we are going to go over each in a little bit more detail. Just know that red blood cells are going to be 95% of the volume of formed elements, and the other 5% is going to be a mixture of white blood cells and platelets. White blood cells are going to be split into two groups, granulocytes and agranulocytes, and just the biggest difference is that granulocytes are going to have larger granules in the cytoplasm than agranulocytes, as well as a difference in the nuclei. The nuclei in granulocytes is going to be multi-lobed, while agranulocytes will not. And the last little composition here is going to be platelets, and we'll talk about those a little bit more on their own here in just a moment. So here's a lovely little picture showing our red blood cells, our white blood cells, and platelets, which you'll notice that there's kind of a big difference between the various cells and platelets in that platelets are cell fragments, so they are going to be substantially smaller. All right, so moving on into the production of formed elements. This is going to be a process called hematopoiesis or hemopoiesis. Again, just the process of blood cell production. They are going to start as stem cells, as all cells begin. These are going to be where all formed elements are derived from a single population. So you can read through that list there. Just know this potentially for a matching question. And then we are going to have chemical signals such as colony-stimulating factors to help regulate development, and erythropoietin is going to be a hormone that stimulates red blood cell development. I do believe we're going to talk about erythropoietin just a little bit more here in a minute, but just in case we don't, in case I'm wrong, which I might be, do make a little note that erythropoietin is going to be released in response to low oxygen levels in your body. So if you have less oxygen, you're going to produce erythropoietin, which is going to stimulate red blood cell development. I always love slides like this, showing this process of making various types of formed elements, because it's sort of like a blood cell family tree. I think they're quite adorable. You do not need to regurgitate this information exactly as it is, but I would maybe look it over and get kind of an understanding of how the different cells relate to each other, where they start from, where they come from, and how we are going to have some of our finished products form. So we've got that bottom level there is our red blood cells, our platelets, and our various white blood cells that I do want you to know. Okie dokie, so moving on into a little bit more specifically red blood cells. We are going to call them RBCs every once in a while, so just make a little note that that just means red blood cells. Their shape is really unique in that they're a little bit bioconcave, sort of like a donut if a donut doesn't have that little donut hole taken out, but it's still sunken in. They are about 7.5 micrometers in diameter. This is a very important thing to make note of. They do not have a nucleus, but they can still survive without having a nucleus. They do not need it. They have everything they need to survive for a few months, and then they'll go be recycled in the liver. But due to not having a nucleus, this makes them nice and flexible and capable of bending or folding, which allows them to pass through small vessels called capillaries. They are going to contain hemoglobin, lipids, ATP, carbonic anhydrase, and that's all they really need. Some functions of red blood cells: we are going to transport oxygen from the lungs to the various tissues of the body, and 98.5% of the oxygen that is being transported through the body is going to be attached to hemoglobin. The other 1.5%, as we mentioned before, is going to be within your plasma. So again, the majority of oxygen that is moving through your body is going to be attached to red blood cells. We are also going to transport a cell waste product, which is carbon dioxide, that is going to be transported from your tissues to your lungs. This is what you breathe out. You are just getting rid of that gas waste. There is a little breakdown there as far as how much is going to be in your plasma, about 7%. 23% is going to be combined with hemoglobin. The other 70% is going to be transported as bicarbonate ions produced as a result of a combination of water and carbon dioxide because of enzyme carbonic anhydrase found within red blood cells. But for the most part, I do just want you to know that carbon dioxide is being transported from your tissues to your lungs to be expelled. Oxygen is being brought in from the lungs to be distributed throughout your body to your various tissues. All right, so let's start talking about the protein that makes up your red blood cells, that is hemoglobin. It is going to consist of 4 subunits, and this is going to make a little bit more sense on the next slide as there is a graphic showing a hemoglobin, so just kind of bear with me for a moment. So globin is going to be bound to a heme group, so for every globin you're going to have a heme. Within your heme, you're going to have an iron atom. That iron atom is going to be what gives blood its red pigment. So if you want to make a little note of that, it's kind of an interesting fact to know. It's also what gives blood that metallic taste, because for every hemoglobin, which is going to be composed of 4 globin, 4 heme, and 4 iron atoms, you get that nice metallic-y taste as well as that red pigment. Moving on to the 3 types of hemoglobin, you have embryonic, fetal, and adult, which are all going to be a little bit different from each other. Embryonic and fetal are going to have a greater attraction for oxygen than adults. This makes sense because, you know, during those stages you are going to be needing a lot more oxygen because you're producing a lot more waste as you are developing, as your cells are growing. But fetal production is going to stop after birth, and then you're going to kind of enter into this sort of adult phase, or starting to phase into that adult phase. There are 3 different hemoglobins that I would like you to know. Oxyhemoglobin, which is going to be hemoglobin that is bound to oxygen. Deoxyhemoglobin, which is hemoglobin that will not be bound to oxygen. And you know what? Sometimes you can't say words, and that's okay, guys. As long as you can spell them, that's fine. That is going to be hemoglobin bound to carbon dioxide. So there we go. Now you know I can't say words sometimes. Okay, so here's where I think bringing this all together makes a lot more sense, and try to focus a little bit more on this guy over here. Sorry, I had to find where I could write stuff out at. Okay, so we have our 4 chains of globin going around there, and they each have their own little name, but don't worry about those for now. Within each of those globin chains, we have a heme group, so that heme group's going to be right there in the middle. The heme is going to have an iron attached to the middle of it, and for each of those little iron molecules, you can hold 2 oxygen. So when it comes to this entire lovely hemoglobin right here, you have 4 globin, pardon my writing, 4 heme, 4 iron, and 8 oxygen, because for each iron you can hold 2 oxygen, right? Do keep in mind that is 8 oxygen, not 80. Alright, so moving on into the life history of red blood cells, we have erythropoiesis, which is the formation of red blood cells. This is going to take about 4 days in total to form a red blood cell. That is the process of producing a red blood cell, starting from a stem cell and then moving on into those various stages. As long as you kind of know them in general, that's fine, but I will not ask you to regurgitate this information verbatim. Moving back into erythropoietin, I think I said this before, just wanted to reiterate it. It is going to be a hormone that is going to stimulate the production of red blood cells, and it's a response from your kidneys, because erythropoietin is produced by your kidneys, to low oxygen levels, low blood oxygen levels, which is known as hypoxia. So make sure you know that hypoxia is just referring to low oxygen, and that is what erythropoietin is responding to. Red blood cells are typically going to last between 110 and 120 days. I believe that's around 3 to 4 months. That is in circulation. From there, they are going to rupture from just, overuse. They've been really flexible up till this point, and they get a little bit on the brittle side. When they rupture, that is called hemolysis. And then from there, the hemoglobin in the plasma is going to be broken down by macrophages. So you can kind of think of macrophages as being sort of like a cleanup crew, if you will. They're just going to pick up all those pieces. So those macrophages are then going to take up hemoglobin released from hemolysis. The globin is going to be broken down into amino acids, the heme is going to be broken down, and the iron is going to be released. We are going to reuse that iron. It's not going to go to waste, it's not going to be expelled from the body, but it is going to be reused for more red blood cells, hopefully. The non-iron part of heme is going to be converted to biliverdin and then turned into free bilirubin. So remember, we were talking about free bilirubin before. This is where it's coming back in. Free bilirubin is going to be joined to glucuronic acid to form conjugated bilirubin. This is going to be a more water-soluble type of bilirubin, which is then going to be added to bile, which, if you remember or if you've been taught at all, we will talk about it more in the digestive system, but bile is going to be a byproduct that is produced by the liver, where all of this is going on. The liver is going to be producing that bile from the recycling of red blood cells. I always like to think of it as recycling or upcycling. We're kind of breaking all the parts down, reusing what we can, and anything that's waste is going to be turned into bile. Bile is that green product that is going to be stored in the gallbladder. From the gallbladder, it is then going to be released into the small intestine and thus pass into your feces and out of your body as waste. Okie dokie, moving on into white blood cells or leukocytes. Leukocytes are going to have a nucleus, unlike their red blood cell cousins, and attract stain in slide preparations. So this is why white blood cells appear to be that more dark purple or a darker color than red blood cells. It is just because they attract more stain in slide preparations. We already talked about their grouping from granulocytes to agranulocytes. Just make sure you know the difference there. and which type of white blood cells are going to be included in each of those groups. Here we have a lovely blood smear slide. All of the kind of pink circles going around there are going to be our red blood cells, while the dark purple and kind of larger cells are going to be our white blood cells. All right, moving on to white blood cells. So the main purpose of white blood cells, also known as leukocytes, is to protect the body from invading microbes, as well as potentially to remove any dead cells that you might accumulate just kind of naturally. There are a few characteristics that are going to help white blood cells move about and perform their functions. The following three are going to be types of movement. So the first is amoeboid movement, and do keep in mind that amoeboid movement is going to be occurring mainly in the cardiovascular system, while diapetesis and chemotaxis are going to occur in surrounding tissues and not necessarily within the cardiovascular system exclusively. So starting with amoeboid movement, this is going to be directed movement. So unlike red blood cells, amoeboid movement is going to be projections of the cytoplasm, which is going to be very unique and more about white blood cells being able to engulf whatever it is that is trying to engulf, whether that is cells or possibly an infection of some type of microorganism. The next one is diapetesis, which I could be saying that wrong, who knows, but we're just going to go with it. But this is where the cell, the white blood cell, is going to become thin, elongated, and move either between or through endothelial cells of capillaries. Imagine really thinking skinny thoughts and kind of squeezing in between maybe a wall and somebody's chair if you're trying to move around them, if they're around like a dinner table or something. But it's making yourself very thin in order to kind of squeeze through the cracks, if you will. So the white blood cells are going to be able to do this, and this is more of a an ability to leave the cardiovascular system to get out into the surrounding tissues, possibly to an infection or wherever it's needing to go to. The last one is chemotaxis, and chemotaxis is going to occur after the last one, so after diapetesis. It's going to be more where the white blood cells are attracted to an infection within the tissues. So at that site of infection, occurrences are going to happen where you're going to have an accumulation of these white blood cells that are going to die, as well as potentially dead cells or parts of an infection that the white blood cells have taken care of. So essentially, think of it kind of like a battlefield. So the dead of both sides are going to be in that area, and in this instance, this is going to be known as pus. So this is when you have a leaking of potentially a whitish fluid from some site of infection. That is what that is. From here, we are going to move on to the specific types of white blood cells that I would like you to know and the various things I want you to know about them. The first is going to be what they look like, some characteristics of them so you can identify this particular white blood cell, as well as some of their various functions and a few little extra tidbits about them. So first we have neutrophils. Neutrophils are going to be about 55 to 70% of all white blood cells. They live for about 1 to 2 days. They are going to secrete a lysosome. So lysosome is going to be a type of digestive enzyme, if you will. So you've heard of something lysing or lysis. We've talked about that term lyse before. That just means it's kind of disappearing, if you will, is one way to put it. So once they become motile, they are going to use a process called phagocytosis, which if something is going to be phagocytized, words, that means it's going to become engulfed. So in this case, neutrophils are going to engulf bacteria, antigen antibody complexes, and other foreign matter, but bacteria is going to be that main one that I want you to know. Next up, we have eosinophils. Eosinophils do pay attention to how their appearance is. They've got those large granules in the cytoplasm. They are also got those multiple lobes for their nucleus. So again, very classic appearances for granulocytes. So a few things I want you to know about eosinophils is that they account for 1 to 4% of all white blood cells, so quite a few less than you're going to find of neutrophils. Their purpose is to enter circulation, leave circulation and enter your tissues during inflammatory responses. They are going to be pretty prevalent in allergic reactions. Their purpose is to destroy inflammatory chemicals like histamines, as well as release chemicals that help destroy tapeworms, flukes, pinworms, and hookworms. So if you are unsure of what those microorganisms are, they are parasites, which they are usually found in your digestive tract, but I think they can kind of escape out into various other places if given the opportunity. But eosinophils are going to be there to destroy parasites more primarily than anything else. Next up, we have basophils. Basophils are going to kind of look more like this dark blob, but you can definitely still see those granules in the cytoplasm, which is relatively characteristic of identifying a basophil. They are the least common white blood cell you're going to attempt to find. They account for less than 1.5 to 1% of all white blood cells. They are going to leave circulation and migrate through your tissues and play a role both in inflammatory response and allergic reactions. These are going to be the white blood cells that are producing your histamines and your heparin. So basophils are going to be relatively prevalent when it comes to like seasonal allergies, if you will. All right, next up is lymphocytes. Lymphocytes are going to be produced in red bone marrow, but they are going to migrate to lymphatic tissue and then proliferate. What this term means is that they are going to grow and then multiply in that area. So while lymphocytes are still considered white blood cells, they are more associated with your lymphatic system. But they will kind of go back and forth wherever they're needed. But they are your body's first line of defense. We will talk about this more when we talk about the immune system, but your tonsils, so located in your throat and kind of around your mouth, underneath your tongue, your tonsils are going to be your first line of defense to your body, and you're going to have quite a few lymphocytes located there. So they have been studied, lymphocytes that is, have been studied extensively with the immune system as they are one of your first lines of defense. And they will make up about 20 to 40% of your white blood cells. Next up, we have monocytes. Monocytes are really cool to me because of the shape of their nucleus, as well as how large they are in comparison to other cells in your cardiovascular system. So first, the nucleus is going to be kind of more of a heart shape, which I find really cute. As well as, again, they're just kind of like these big cells, but they are going to remain in circulation for 3 days and then leave circulation to evolve into macrophages. So they are phagocytic, so that means again that they're going to engulf whatever it is that they are engulfing, such as some type of invading microorganism, and they can break down antigens and present them to lymphocytes for recognition. Now, lock that away for later, We are going to talk about that more extensively when we talk about the immune system, but that is a very important thing that our monocytes, specifically our macrophages, are going to be able to do. So lock that away for later. We're going to talk about it later. And then again, monocytes are going to account for about 2 to 8% of all white blood cells. All right, so that's it for your white blood cells. Time to move into platelets. Platelets, one of the big important things you need to keep in mind is that platelets are fragments of cells that have been pinched off from megakaryocytes. This is going to occur in your red bone marrow. Platelets are constantly replacing themselves. They don't live for very long. But they're constantly needing to be replenished, and they are acting as a fail-safe in case one of your blood vessels becomes ruptured or nicked, or maybe you cut yourself or something. If you did not have any platelets that are replenishing themselves constantly, you would bleed out. That would be very not good. So the surface of platelets are going to contain glycoproteins and proteins that allow adhesion to other molecules, that is to say, collagen. So not only are they going to block up whatever it is that is causing that rupture, maybe it's like a cut or a slice or whatever it is, but they are going to stick to each other as well as create a fiber net. And we are going to get into that a little bit more. But just know that platelets serve the purpose of preventing blood loss. That is the big thing. They're going to form a platelet plug as well as promote the formation and contraction of clots. So big important thing, even though they are quite small. Speaking of stopping bleeding, we are going to talk about hemostasis, which is going to be the arrest of bleeding or the cessation of blood loss. So, the purpose of this is if we cannot stop bleeding, it's going to cause even more excessive bleeding from a cut or torn blood vessel that can result in a positive feedback cycle consisting of ever decreasing blood volume and blood pressure that disrupts homeostasis and can result in death. So these are the events that will prevent excessive blood loss. So the first is going to be vascular spasms. This is going to consist of vasoconstriction of damaged blood vessels. So remember the difference between vasoconstriction and vasodilation. Vasoconstriction is going to tighten that area. It's going to make it smaller so that there is less blood traveling through. Meanwhile, vasodilation, just to make sure we know these terms, is going to expand that area and allow more blood flow. So in this case, we are wanting to constrict so that our blood vessels are smaller, which are then going to cause less blood flow to go through. This is going to be caused by thromboxanes from platelets. It's going to be released from our platelets and endothelin from damaged endothelial cells that are lining the blood vessels. The second step is going to be a platelet plug formation. So this is going to be where our platelets are going to activate, which I know it sounds like something almost like a superhero or a robot or something like that. They're going to activate, but they're going to become sticky. Now they can't always be sticky. If they were, they would clog up your arteries and vessels and things of that nature, and that would be no bueno. So in this instant, they are going to become activated and stick together and form this platelet plug. Next and last is going to be coagulation or blood clotting. The next few slides I'm going to just kind of gently roll through. If you would like to read through them a little bit more closely, you are more than welcome to. I think it's fantastic information, but I'm not going to go into as much depth as that last slide went into. I think it covered everything pretty well. So again, if you want to sit and read through these, please do. Alrighty, let's talk about clotting pathways. There are two pathways which you can make a little note that in the end, they are going to converge to form the common pathway, which then will cause the formation of a fibrin clot. If you want to read up a little bit more about these various tissue factors that are included on this slide, you can turn to page 663 and take a look at table 19.3 in your textbook. But I do want to make a little note here about the extrinsic and intrinsic pathways, just to make sure you know which one is which. Extrinsic is going to begin with chemicals outside of the blood. So this is going to be tissues surrounding that damaged area, which are going to release tissue factors, which that is what all of these various Roman numerals predecessed by factor are talking about. These are the chemicals that they are going to release that are going to get the ball rolling, if you will, in order to form a fibrin clot. So you have those extrinsic pathways, which are going to be chemicals outside of the blood, and intrinsic pathways, which are going to begin with chemicals that are part of the blood. So you can read through that chart, that table 19.3, but I will not ask you specifically, what does factor X do, etc., etc. So this is fantastic information, but I am not going to ask you specifically what does each factor do. So moving on into what happens after the extrinsic and intrinsic pathways converge, they're going to create this common pathway. So first we have prothrombinase, which is going to be formed from both of those pathways converging, and then prothrombinase is going to convert prothrombin into thrombin. Try saying that 5 times fast. From there, thrombin is going to convert fibrinogen to fibrin. And that is where I want you to have like a little highlight there. So we are doing all of this with the common goal of forming a fibrin clot. That fibrin is going to form kind of like a sticky net, if you will, to hold some red blood cells, platelets. It is going to create this nice clot in order to block up wherever it is that blood is escaping from. And then if you want to finish off this little slide here, the thrombin is then going to activate that factor, which is going to stabilize the clot, but more importantly, the things I said before. All right, so now we're going to move into the control of clot formation. This big important term up here, anticoagulants, this is going to prevent coagulation factors from initiating a clot formation. Now you might be saying, why would you want to prevent coagulation? And that is at any point when there isn't a reason to have coagulation. Typically coagulation is going to occur when your coagulation factor concentration exceeds a given threshold. Typically this is going to be at a site of injury where that threshold is going to be exceeded. So if you're just going about your day, doing your own thing, your body's doing fine, you don't want clots to form. That would be not good. So some of the anticoagulants that we have include antithrombin. It's going to be produced by your liver and slowly inactivates thrombin. You have prostacillin, which is going to be a prostaglandin derivative from endothelial cells. It's going to cause vasodilation. So again, remember, dilation is going to open up those vessels and increase blood flow, as well as inhibit the release of coagulating factors from platelets. And then from outside the body, for example, if you were giving someone some type of transfusion, so like a blood transfusion, heparin, EDTA, and sodium citrate are going to be examples of anticoagulants that may be administered to patients. When we get into the reproductive system, we might talk about sodium citrate a little bit more when it comes to Viagra. So kind of an interesting little thing to get your blood racing, haha, for a future topic. So again, just to kind of reiterate, why would we want to control for clot formation? Obviously, you don't want clots to be forming when they shouldn't be. And this includes kind of stopping that process once a clot has already been formed. We want to cease and desist so more clots are not formed and causing problems. All right, let's talk about clot retraction and dissolution. So clot retraction is going to be where you have the clot condensing into a compact structure. From there, as the clot is retracting, it is going to be squeezing out serum. So if you remember talking about serum before, it is plasma where clotting factors have been removed. And as that clot is retracting and serum is being squeezed out, the retraction is going to pull the edges of blood vessels together, which in that process, it's going to help stop blood flow, reduce infection, and enhance healing. So very, very important process. From there, the clot is going to start dissolving over time, over a few days potentially, in a process called fibrinolysis. From there, we're going to have an enzyme called plasmin hydrolyze the fibrin of the clot. So that means that it's just going to break the fibrin and, in the end, dissolve the clot. Let's jump into blood grouping. Blood grouping is going to be our little predecessor into talking about transfusions and infusions. So transfusion, probably something you've heard of, something you know about. It is a transfer of blood or blood components from one individual to another, typically when the individual in need is lacking in some capacity. And an infusion is going to be the introduction of fluid other than blood. So something other than blood is being put from one individual into another. So how this is going to happen is we need to determine the individual's antigens or agglutinogens. These are going to be structures on the surface of red blood cells, and they are going to need to match from the donor and the recipient. Antibodies or agglutinins can bind to red blood cell antigens and result in an agglutination or a clumping or a hemolysis or a rupture. So in this instance, that means that there isn't a proper match from donor to recipient, and you are going to have a rejection of the donor's blood or whatever it may be to the recipient, and that can end up being a very, very bad thing, of course. So we are going to talk about these various groups, so the ABO group and RH factors. All right, so talking about the ABO blood groups. So probably you have heard of type A, type B, type AB, and type O, but maybe you don't know what that exactly means. If you do know your blood type, I find this information to be absolutely the most interesting thing. I think it should be mandatory that everybody know what their blood type is. That way you can either donate when necessary or when needed to someone who may need it. If you are matching their blood groups, it's really important to donate. So let's talk about it. So what we have first is going to be type A, that first column there. We can see that for our type A, we have red blood cells with type A surface antigens. And within the plasma, we're going to have anti-B antibodies. You'll notice that the anti-B antibodies have a specific shape and that they're not going to be able to attach to the antigen A on or the A antigens on the red blood cell's surface. Moving just to the right, we have the type B blood, and you'll notice that the anti-A antibodies in the plasma of type B blood also do not match and can fit into the B antigens studding the surface of the red blood cell. But you will notice in this lovely little graphic here that the anti-A antibodies would be able to fit on the antigen A studs, while the anti-B antibodies would be able to fit on the antigen B studs. So in the plasma of A, you're going to have a way to make sure that there's no antigen B's able to survive, that those antibodies would take care of that situation. So what I'm getting at is you have puzzle pieces that are not going to be able to fit together, and then puzzle pieces that will be able to fit together. So if someone who is type A tries to donate to someone who is type B, you will not be able to do that situation due to the antibodies in the plasma of the recipient. So if I am type A, which I am, and let's say someone with type B tried to donate to me, or they mistyped my blood type, and they gave me type B blood. Well, my antibodies, my anti-B antibodies in my type A blood would then attach to the antigen B antigens that are studding the surface of the red blood cells of my donor, and thus destroy them, and my body would go into basically an immune response, and that would be really, really bad. So that is why you have to do blood typing. Now, the types of blood that are going to kind of throw you off a little bit and be a little bit weird is the type AB and type O. Type AB is going to be red blood cells that have both antigens A and B studding the surface of the red blood cell, while the plasma is going to contain neither anti-A nor anti-B antibodies. If it had either one of those, then obviously there would be a problem, and one of those antibodies would start attacking the antigens studding the surface of the red blood cells. Now we get to O. O has neither antigen A nor B studding the surface of it. That is why it is O. There is nothing on it. While the plasma contains both anti-A and anti-B antibodies. So that is kind of an interesting little thing about ABO blood groups, maybe that you didn't know before. So when it comes to transfusions and matching blood types, type A blood has anti-B antibodies and type B blood has anti-A antibodies. So obviously you cannot donate from someone who is A to B and vice versa. It is suggested that these antibodies are present because of exposure to A and B antigens on bacteria and food. So the purpose that, type A blood has those anti-B antibodies and vice versa for B to A antibodies. As we said before, donors are going to give, recipients are going to receive, and do make a little note here that type O is the universal donor, but I want to make a little correction to this slide. O negative is the universal donor, and we'll talk about kind of why here in just a moment. O can actually cause transfusion reactions because of the antibodies in blood plasma, but a lot of times they will take the plasma out of the transfusion if they are able to, I believe. So that's usually not really the biggest problem there. Alright, the next few slides are going to be little graphics of agglutination reactions occurring. So here we are going to have a type A blood donor donating to a type A recipient. So that's a good thing. We are happy. It's what we want to see, because you can see these anti-B antibodies are not going to be able to connect to our antigens here. They don't fit the right shape. Again, think about like a puzzle piece. It would have to fit perfectly. Moving on now to a type A donor to a type B recipient. This is going to be a bad situation. It's going to be no bueno, because we have our antibodies, our anti-A antibodies located in our plasma are going to be able to perfectly connect and cause a bad reaction, or clumping. Things will start to happen where the donor's blood is going to be rejected from the recipient. And if you do the blood typing lab, you'll see that there becomes a difference when you have a situation like this, and this is how blood typing is done professionally, actually, is to see if there is a reaction, a clumping, a change in consistency of blood. When you add these antibodies in, it will cause some type of reaction, and that's how you know what type of blood that you've got. All right, moving into the Rh blood group. This was actually something that was discovered via the unfortunate loss of many rhesus monkeys. The research that was done, obviously ended in a lot of fatalities, but that is where we get that term Rh. It is because of rhesus monkeys. So you can look that up if you're a little bit more interested. I think it's kind of cool, but also quite sad. But regardless, I digress. So there are two types when it comes to Rh groups, or there's two Rh groups, in fact. Rh positive, meaning that there is the presence of antigens on the surface of the red blood cells, or Rh negative, where there is no presence of those antigens. Now, where this comes into being a problem, aside from donations, is where you have hemolytic disease of a newborn, or HDN. This is where you're going to have an Rh positive fetus with an Rh negative mother. This can occur late in pregnancy, where you have Rh antigens of the fetus crossing the placenta. This might possibly be through a tear in the placenta or during delivery. The mother will start to create anti-Rh antibodies, and that's just going to be that immune response to that what her body perceives as an infection. A second way that this can happen is during an Rh positive pregnancy, where it might initiate a secondary response, and this HDN, or possibly by an infection of the RHO gam, where it contains antibodies against Rh antigens, where the antibodies will then attach to any fetal red blood cells, and then they are destroyed. All right, moving into diagnostic blood tests. The first is going to be blood typing. This is going to determine what your blood type is. So whether you're A, B, AB, or O, depending on what type of results you get after you test that blood. So up here in the upper left corner, I did kind of very poorly, I apologize, draw out how some of these blood typing kits can look, and they're pretty rudimentary, but if it ain't broke, why fix it? It's a fantastic way to test blood types. So what they'll do is they'll put the person's blood into these, pardon my computer freaking out, you're going to put this blood into these wells, and what's that going to do is we're going to put in the antibodies, so antibody A and antibody B, as well as the antibodies associated with Rh, and if you get a reaction, then you know that, obviously it can't be that. So what they are looking for when it comes to these blood typing kits is for some type of coagulation to occur If you do have coagulation, then that means that that blood is going to be able to be affected by those antibodies. So, makes sense. Next is going to be cross-matching. That is where we have a donor blood's cells mixed with recipient's serum and vice versa, which is going to then look for agglutination, just like blood typing is. You are looking for a reaction, and that reaction is going to tell you whether or not that person's blood contains the antigens that can be agglutinated with those antibodies. Next is going to be a complete blood count. This is going to be looking for the number of red blood cells per microliter of blood. If you're looking at a red blood count, possibly you're looking at a hemoglobin measurement, which it's going to be measuring the grams of hemoglobin per 100 milliliters of blood, and then males and females are going to differentiate in that. A hematocrit measurement is going to be the percent of blood that is specifically red blood cells, and it's going to look for normocytes, microcytes, and macrocytes. And then, of course, there is a white blood cell count. Much like a red blood cell count, it is looking for some type of range of white blood cells per microliter of blood. So again, this is what I was talking about when it comes to blood typing, what it kind of looks like, a better picture than I could draw. But you are looking for some type of reaction that is going to mean that the antibodies that you put into that little drop of blood are reacting to the antigens that are studding the surface of the red blood cells. So if you get some type of reaction, then you know that there are antibodies reacting to those antigens. Here we have a hematocrit. So you are going to put this sample of blood into a centrifuge while it is in a hematocrit tube, and this is going to show you this separation of plasma, white blood cells, and red blood cells. And so obviously, as you can see from this little illustration, there is a difference between males and females and how much plasma to red blood cells there's going to be. And then here is a list of other tests that can be done. You can kind of look over this at your leisure if you'd like to. The last thing I'm going to tell you about blood is just a few little fun things. And I say fun, but maybe they're not so fun. But I've always found very interesting is that blood in large quantities is not edible. Although in small quantities, like think teaspoons, blood is edible, but you can't just go about drinking gallons of blood at a time. The iron in blood is going to become toxic because your body has no way to properly digest iron. So I always think about my grandmother telling me when I cut my finger to, lick my finger. I know that kind of sounds gross, but you've all done it. But I received a cut on my finger, and she told me to lick the blood and swallow it in order to put it back into my system. And obviously, if you know basic anatomy and physiology, you know that that doesn't work, and that you are just digesting those products. You are not actually putting them back into your system the way that they were previously, but there is no great way for your body to digest an exuberant amount of iron. So eating blood or drinking blood in excess will actually become toxic in your body and can kill you, or at least make you violently ill. So with that, that is chapter 19 on blood.